All right, well, it is 3:01, so respecting everyone's time, we will get started. Good afternoon, everyone. Thank you for joining us today for a presentation from Ellie Stier, the epidemiologist from the state, who will be sharing and discussing Michigan HAI data trends over the course of the COVID-19 pandemic, and help us understand how our state's numbers compare to national data with the recently published CDC HAI report from Shea. Next slide, Kelsey. And then just a quick reminder, please use the chat box to provide your name and email address so that we can follow up with you after the presentation for your CE and IPU credits. This webinar at CEs, it will be provided with this webinar. And then also what we're doing is we're going to table the questions. So during the presentation, if you have questions, you feel free to drop it in the chat, and then we will go over the questions after Ellie's presentation. And then for everyone on the call today, especially our IPs, we just want to say thank you to our IPs and happy International Infection Prevention Week. I'm going to hand the floor over to our APIC Great Lakes Chapter President, Amanda Valico, for a brief message to the group.
Hi everyone, it's Amanda, and happy International Infection Prevention Week. We just wanted to also do a shout out to our APIC Great Lakes members. You guys are great. We appreciate everybody's continued support, and it's been so great to see everybody come together to teach and learn from each other throughout the pandemic in all of these different ways and over Zoom calls. So thanks for all that you do today and always, and thanks for continuing to support APIC Great Lakes.
Thanks, Amanda. I concur with everything you say. Our IPs are just simply amazing. All right, and then now I'd like to introduce our speaker for today. Ellie Stier is the NHSN epidemiologist for the Michigan Department of Health and Human Services in the SHARP unit of the Communicable Diseases Division. She is a 2016 graduate of Michigan State University's Master of Public Health program, Go Green, and has joined the SHARP unit in 2018. She is the state's subject matter expert for CDC's National Healthcare Safety Network Michigan Group, which includes voluntarily shared HAI data from acute care and critical access hospitals in Michigan, and is responsible for analysis, oversight, and coordination of these data. Ellie, we've been looking forward to your presentation, so I'm handing the floor over to you.
Hi, thanks so much. Let me just get my screen prepped here and then we'll get started. Okay, great. I think I've got that all set up. So thank you again, Chow, for that wonderful introduction. And thank you all for having me today. I'm very excited to be able to present to you some HAI infection data that we saw through the COVID-19 pandemic. So as Chow mentioned, the title of my presentation today is the Healthcare Associated Infections and COVID-19 Pandemic, a summary of Michigan data that was reported to the National Healthcare Safety Network. So just to give you a little bit of a background again of who I am the NHSN epidemiologist. I sit in the SHARP unit, which stands for the Surveillance of Healthcare Associated and Resistant Pathogens unit in the Division of Communicable Diseases at Michigan Department of Health and Human Services. And so again, thank you for having me today, and I'm really looking forward to being able to share this data with all of you today. So just to give you kind of a brief overview before we get too far into the weeds here, this presentation is similar to a data summary that was published by CDC in the Infection Control and Hospital Epidemiology Journal. It is an open access article. We'll come back to this article again at the end of the presentation and kind of discuss the highlights of the results and discussion section as it relates to the data that I'm going to share with you today, which is specific to our NHSN Michigan group. And to give you a little background about the data, this data was gathered from our NHSN group, which is voluntarily shared with MDHHS. So we have hospitals voluntarily confer rights to share their HAI and some AU data with us so that we can use that for public health surveillance purposes. And additionally, we do some reporting on that as well on our website. So therefore, just so you may know, if you are familiar with this article, if you've already read it, it may slightly differ from that data that was published in that report, as that's national data, and they have all of the hospitals that are reporting into NHSN. Well, we have those that are voluntarily sharing. So we do miss a few from our group that CDC may have access to. This data was presented to represent a comparison between the quarters in 2019 and 2020 for each infection type. And this is also for the device-associated infections. And then furthermore, in this data set that I'm going to show you today, I further stratified that by location type. So that is a little bit different than the other article and data that you might find elsewhere. So that is specific kind of to our Michigan group here. Percent change was used to compare quarter data and is calculated as the difference between the 2020 quarter SAR, the 2019 quarter SAR, then divided by the 2019 quarter SAR and multiplied by 100 to give us a percentage so that we can kind of compare. And again, this is a comparison of 2019 and 2020 quarter one, and then 2019 and 2020 quarter two. So not comparing all the way across, but just each quarter individually so we can make sure we're accounting for that seasonality of data as well. And in the CDC report, facilities were excluded if they did not report for all quarters, which you might remember, we have a handful of facilities. If you've been a part of some of these other meetings that I've presented at, you may know that we did have a few facilities that did not report during the CMS reporting exemptions period. And so again, the CDC report excluded a lot of those facilities that didn't report. I did not. So that may also kind of affect some of those numbers that you might see. Okay, and this slide illustrates our Michigan daily COVID-19 cases for 2020. This is a snapshot that was taken from the michigan.gov/coronavirus website. And what I wanted to do is kind of overlay the quarters that we're talking about here so you can kind of see what we were sort of managing case-wise in the state with the data that I'm going to be presenting with today, because all of our HI data is by quarter. So you can kind of see here that first quarter, March 20 through July. And again, we were early in pandemic there, so reporting things have changed a lot. So that could also attribute to some of these, but you'll kind of notice that stark difference there in 2020 quarter four. We were sort of at one of our first and second peaks of the pandemic. Okay. So now we're going to kind of move in and go through a lot of tables. We have a lot of tables that look like this. They are a little overwhelming, so we'll walk through them all. So please don't be intimidated. And I'm happy to answer questions later if you kind of notice some things, but I'll start through and start with our catheter-associated urinary tract infections. What I do want to highlight is that percent change column, which is what we were just talking about sort of in our about the data section. And going through, if you notice, the percent decrease is noted in a green, and then our percent increase is noted in red. So you'll sort of notice as we drive through these slides, a lot of that percent increase is observed in quarters 3 and quarter 4. So again, to begin, we'll start with CAUTI, and this is for all locations, then again stratified by ICU locations and what we call ward plus locations. So that's wards, step downs, things that are described as other. But what you'll see here is a approximately 30 and 40% increase in quarter 3 and quarter 4 for all locations. And that CAUTI SIR change from, so if we're looking at quarter 3, we've got a 0.64 and that changes to 0.814. So we'll notice kind of a 30% increase there. So that's what we're looking at through these slides. Moving on to the ICU locations, we did see a greater percentage increase in quarter 4, which is about 60%. And then in those ward plus locations, we see a slight increase in quarter 2, almost 4% there, but a more dramatic percentage increase between quarter 3 and quarter 4, once again, as you'll see in those all locations and ICU locations. Moving on to our central line associated bloodstream infections, or our CLABSIs, slightly different because we saw a sizable increase in quarter 2 of about 60% there, which would have been much closer to the beginning of the pandemic. If you can kind of go back to that second slide that I showed you when I overlaid those quarters. And that trend continues on for the rest of the course for quarter 3 and quarter 4, so about 40 and 50% there. In ICUs, again, noting that large percentage increase in Q2, but then again in Q4. And then for wards, more similarly to what we saw for CAUTI, which is a percentage increase being observed in that Q3 and Q4, but still something about 15% in Q2. And then moving on to our ventilator-associated events, we saw a percentage increase in all quarters for all locations, and then again for ICU locations, and just a little bit different in our ward locations. We actually saw an improved SIR for 2020 Q4 as compared to 2019 Q4, which resulted in about a 20% decrease. But overall, noticing here that all locations, our ICU locations and our ward locations, we did see quite an increase. And this is comparative to what is in that CDC paper as well. A different and very unique observation among our CDI events, and we did notice a percentage decrease in all quarters in 2020 from 2019. So 20% change between Q1, about a 35% for Q2, 13% for Q3, and about a 2% decrease in Q4. So all decreases across the board here. Our MRS ones being noted in Q2 and Q3. Okay, and last but certainly not least, we're gonna move on here to the surgical site infections. I do want to bring up a couple of points here before we get too deep into this data. However, in Michigan, we have pretty steadily been seeing an increasing trend in SIRs for some time across most of our common SSIs, which would be our colo, HIS, K-Pro, and H-Pro is what we kind of keep an eye on here in Michigan. So just wanting to note and recognize that these data, while still potentially could be impacted by the pandemic, may still be increasing as what we had been seeing before. So it could be also related to the fact that we just have been already seeing an increase in these data. And there's a little bit more sporadic sort of changes, I think, in this data. So we notice, again, kind of not like other infections, noticing a percent change increase for those colo events from Q2 to Q4, appearing though to be a little bit smaller in those increases, not really in the 40s, 50s, and 60s, but more like 15 and 30 there. For HIST events, mostly noting a decrease. So that is a little bit different than some of those other HAIs, except for Q3, which we're noting a percent increase there of about 30%. And then again for, I'm sorry, excuse me, I've lost my place here for a second. Yeah, so then moving on onto the K-Pro, again, noting the same sort of trend that we've noticed for HIST here, mostly decreasing except for a pretty large increase in that K-Pro for Q3, from moving from 0.9 to above 1, so 1.5 there in that quarter. And then for H-Pro, noticing a percent change increase in all quarters there. Okay, and then I want to move on and I want to discuss a little bit about device utilization ratios. We can see a pretty similar trend in those that we would find in our infection ratios. So noting again, these are devices being utilized. So our devices being used during these quarters. Though the percent change is much smaller, there were percent increases in catheter utilization starting in Q2 and moving forward. There was also observed in central line utilization with a sizable increase of almost 20% between 2019 and 2020's Q4. And then finally, there was a nearly 50% increase in ventilator utilization between 2019 and 2020 in Q2. Almost no change in device utilization for Q3, but then notice a percent increase back in Q4. Okay, and that kind of concludes the data spill and all of that there. So I know that was a lot to kind of take in, but overall just kind of noting, we did notice increases in SIRs and SURs between 2019 and 2020. So 2019 being our pre-pandemic and 2020 being our pandemic year. And so in the SHARP unit, I host a bi-monthly NHSN group users meeting, which we invite all of those hospitals that share that data with us, their IPs or maybe their NHSN reporting entity, to join us, and we kind of go over new changes in NHSN. So we presented this data that I just presented to you here at our August meeting, and I kind of wanted to utilize the opportunity as a mini focus group, if you will, and get some insights from our boots on the ground, all of you that work so hard every day, and kind of get what were your thoughts as to why you noticed these changes, or if you didn't notice these changes, what might you consider could be a potential reasoning behind some of this change in our HAI data from 2019 to 2020. And I asked them the following questions. What do you think contributed to these changes? Was it an increased patient population and or patient comorbidities? Changes in infection control practices? Was it due to low PPE, staffing shortages, staffing turnover, or was there something completely different that I hadn't even considered, as you might have noticed in your hospitals that hadn't been mentioned? And so you can kind of note by this word cloud here on the right of the screen, you can see some of the popular responses, which included changes in device use, low and modified PPE use, changes in the population of patients that were seeking medical care, so also known as maybe they were more critical or presenting with those comorbidities, staffing shortages and turnover, needing to make changes to the bed types and the locations to meet those care needs, changes in infection control practices, which again, we'll talk about here a little bit more in the next section. And then also, I wanted to share some direct quotes that I pulled from that meeting, which I thought were really important and really kind of highlighted some of those bigger themes there. So lack of access and visibility to sites and additional pressure as related to maybe some of those changes in infection control practices. Proning position of patients on ventilators, which provided prudential challenges with ease of managing those devices properly. The biggie, shortages in hand sanitizer and disinfection products. That was a huge theme, and we kind of lumped that in together with changes or low PPE use. The complexity of the patient load was changing, so we were seeing more complex cases and critical care. More long-term patient care, so more long-term care residents were seeking care in hospitals during this time, having to open extra units that were not normally used for inpatient care, and then changes in process and re-education. So that sort of was related to that staff changing and turnover. So changes in training, changes in infection control training, et cetera, to sort of meet the needs of that understaffed hospital or facility. And then as promised, I just wanted to walk and talk through the CDC publication, which was titled The Impact of Coronavirus 2019 or COVID-19 on Healthcare Associated Infections in 2020, a summary of data reported to the National Healthcare Safety Network. You may notice is similar to the title of my presentation, and then was published in the Infection Control and Hospital Epidemiology Journal earlier this fall. This was a really interesting paper, and if you want to read more, I do have that cited at the bottom of this slide, and I would definitely recommend, especially if you're interested in a national view of the changes in HAIs during the pandemic. We did see similar results in our Michigan data, so you won't be surprised at what you see. However, it does note maybe some bigger changes or some bigger increases in some of those infection types. And then just to kind of give you a brief summary of what this slide is, we're really kind of limited to just a very small section of that paper. So if you want to get into some of the things like they had discussed in the CLABSI increases, maybe some of the types of isolates that were identified, which was interesting. So that kind of stuff, it gets into some of those deeper details that we didn't talk about today. So definitely a good read if you're interested in more of this information. So I just highlighted a small section, which is sort of the conclusions that they make from a similar data analysis that I shared with you today. And what did they state were the potential factors that could have resulted in those changes? So we kind of have like a Michigan view, that little mini focus group that we had, and then sort of what did we see in this national paper as well. So on the left, in those first couple of boxes, that purple blue color, I've highlighted the conclusions of the paper, which were 2020 Q3 and 2020 Q4 saw large and significant increases in the CLABSI, CAUTI, VAE, and MRSA bacteremia SIRs. You may note that is sort of similar to what we've highlighted today. The CLABSI SIR experienced the greatest increase among all HAI types. Again, similar to our data, we were looking at about 60%. I believe in this paper, it was close to 70. CAUTIs and VAEs were also reported more frequently in 2020 than 2019. So actually the number of CAUTIs and VAEs were reported more, which is something that we did not look at today in the Michigan data. And then the possible factors that they contributed to that is over in that blue-green box, sort of to the left or to the right there. Impacts of hospital COVID-19 prevention activities on central line insertion and maintenance practices. Increase in the number of hospitalized patients in 2020 that required ventilation. An increase in patients' average duration of ventilation. So number of days that they were actually ventilated could be attributing to sort of that increased VAE number in SIR there. And then moving on down, just one more box down, looking at the decreases in these CDI SIRs during 2020 as compared to 2019. Again, we noted that in each quarter, there actually was a percentage decrease in CDI. And what could have been the possible related factors to that, which is the increased focus on hand hygiene, environmental cleaning, patient isolation, and use of PPE that would be used to treat and care for COVID-19 patients. Continued inpatient antimicrobial stewardship programs, which I really want to highlight as sort of a wonderful notice that we didn't have to notice a bad change in. So that's great that we still noticed a lot of facilities and hospitals were still continuing to use their antimicrobial stewardship programs. And then a marked decline in outpatient antibiotic prescribing. And that sort of concludes my presentation for today. So I'm definitely willing to take questions now if that's an appropriate time. And thanks so much for having me. And I look forward to answering any questions that you might have.
Thanks so much, Ellie. So I have not actually seen any questions in the chat box yet. So as folks are thinking about it, one of the things that I wonder if we might spend some time digging into is the slide you brought up a few back that's had insights from our hospital partners and had a few different questions on it. Yes, this slide. So I know you shared a little bit about what those responses were. I recognize that not all of our APIC Great Lakes members are from hospitals. So I think that might be an opportunity for us to open the floor to our ambulatory surgery partners, long-term care, other care settings to sort of get their take on this. And then after that, I would like to dig into the hospital feedback in some more detail as well. So I guess where we'll start is for those of you who don't work in a hospital setting, what is your reaction to this? Is it similar to what Ellie shared for hospitals, or any thoughts you have on the questions that are listed here on the slides?
Ellie, I did see one question that just came up. Maybe we could ask right now is, do we have, were the cases primarily in COVID-19 positive patients?
So that is a great question. And I actually have received this question several times. And unfortunately, I don't have a data source that would be able to describe that. So NHSN collected COVID-19 data in hospitals for a very short period of time. They decommissioned that COVID module for hospitals in July of 2020. So they only collected for a couple of months. After that, they did have an option for hospitals when they were entering these events into NHSN to mark whether or not they were a COVID positive patient. However, I do believe it's an optional variable. So if we were to dig into that, we may be limited to the sort of patient population to look across there, as it may not be something that was always selected when entering these events. But it is a great question. And I also wonder the same thing. And hopefully there may be some point in time where we can kind of cross-reference a data source for that. But at this time with this data, there was no way to kind of observe if these were all COVID-19 patients.
Thank you.
Just checking a few of the additional comments that have come in are all very similar. Lisa saying they should make the field mandatory, and Barbara saying she agrees. So, you know, we'll raise our voices up to the, you know, national powers that be and see. But, you know, at this point in the pandemic, you know, we've lost all that time, right, of the COVID cases that have been reported, or the HAs that have been reported with or without that COVID diagnosis as well. So I guess we'll see what we can do. But
Hey, Kelsey, I'm off mute now. I wanted
Hey,
to
Lisa.
share that with Ellie and the team. We're submitting this for publication. We did look at thousands of hospital onset bloodstream infections across Ascension in 69 of our hospitals. And we were able to match that data up to COVID, either ICD-9 code at discharge or PCR results. And we found with strong evidence, statistical significance, that most of the infections were in the COVID population. So initially, I thought it would impacted everybody, but until we teased out COVID versus non-COVID, it was clear to us that there must be something with the medications and the immune state of a COVID patient susceptible to a hospital-acquired infection versus everybody in the hospital that was really going through the same physical circumstances, the staffing, the practice changes, the crowding, the stress, the PPE, but yet our non-COVID patients did not have an increase in their hospital onset bloodstream infections. So we are, advocating that the CDC looks deeper at COVID versus non-COVID in the HAI database, because that's the only way we're going to tether out prevention going forward, because as we all know, one size doesn't fit all. So, and I think the staffing shortages and the staffing turnovers, although they are impactful, I think in general on quality outcomes, I think that might be a red herring with the increases in HAI.
Lisa, this is Chow. One thing I struggle with is how they defined whether a patient is COVID or not with the infection. Is it the patient having an active COVID infection at the time the HAI was identified, or what if the infection was resolved? Do we mark that as a yes, a positive COVID patient? So how did you guys define that?
So, yeah, it was positive on that admission or ICD-9 code consistent with COVID diagnosis at discharge. So one or the other. We weren't able to tease out onset of HOBC versus PCR positive date, but it was just the association of being positive on that admission. Yeah. So it might have been something with the isolation too, right? With bloodstream infections, you're thinking mostly about vascular access care and basic hygiene practices. So it might have been just the sheer fact that they were in isolation. And there were potent, we know from studies that there's less visits into isolation rooms, and especially with COVID, we know how we were bundling care needs, and the nurse became the everything person, from the housekeeper to the respiratory therapist. So it might be by association, but it certainly, at least in our analysis, did not seem to impact non-COVID. Found that COVID patients were likely to come in with a community associated BSI. So that indicates that they're a different profile. COVID patient, an average COVID patient is a different type of patient than an average hospitalized patient, right? As far as age, comorbidities, and what brought them in the hospital was the COVID. So not renal failure or some other significant comorbidity. So there's so much opportunity for study here, and I hope that the APIC Great Lakes members can grasp this opportunity to dig into their data and really consider publishing it, because that's the only way we're going to learn about this disease and the impact on healthcare and HAIs is by publishing. Even negative, non-findings are important too, right? Not just when you find associations, but non-findings are important too.
Lisa, thanks so much for sharing your perspective. And I see a comment in the chat from Sharon, who's asking or suggesting maybe that the state send a query to hospitals to look at their COVID status in relation to HAIs, because they also found evidence that most of the increases seen were specifically within that COVID-19 patient population. So Ellie, I don't know if you have any thoughts or comments or reaction to that from the state standpoint.
Yeah, I mean, I would agree fully that's a great, again, that question is available on NHSN. So I always opt for, even if it's optional, definitely please be reporting as much information as possible. Because as Lisa had pointed out here, I think, and so many others, that this is something that we can't tell until we have the information. And so I agree that there's something to be said there. However, I don't know if I can speak necessarily for the state, but I can just say, oh, and my laptop is telling me it's gonna die. Sorry about that. That, yeah, I fully am on board, and I agree that hospitals should be looking at that data if they can, even if they're not getting something directly from us to tell them to do so.
So any other thoughts? Lisa, please.
Well, I was just going to add, Kelsey, the other obvious thing is when you look at the trends, whether it's the CDC, they did a publication in the spring prior to the one you talked about today, Ellie, they did, where they looked at regional variations in HAI, and it totally mapped to where we were regionally seeing COVID surges. So it's kind of like the writing was on the wall there, but you know, you get distracted thinking, well, it was all these other circumstances. But now, you know, my brain is narrowing more down. What is it about a COVID patient infection specifically that predisposes the body to an HAI? And, you know, the list could be endless, from all the steroids, immune dilators, you know, there's just so many things those patients were put on and went through, you know, while they were in the hospital with COVID. So, but you can see it regionally as well. And just like your data, Ellie, where we showed, you know, your surges came when we surged.
Yeah, Lisa, I totally agree, especially that little bit there that you put at the end. I think that really relates to that ventilator data and the days that those patients are on the ventilator. So we do know that there is likely an association with HAIs and then device utilization, right? And so definitely with COVID-19 patients, we know that a good part of their treatment is being on a ventilator. So it does sort of seem to mishmash up there with what we would expect and what we're seeing, and the fact that those, you know, VAE utilization ratios went up in addition to our infection ratios going up. And you can probably see that with any other risk factor for these HAIs as well. I don't think it's limited just to VAE. So agree that I think that's really important to know, what are those risk factors and are they more prevalent in our COVID patient population, or are they the same as our sort of study group, if you will, or our other group of non-COVID patients?
Right. We know central line, you know, SURs went up, and we also know that in our CLABSI analysis, most of our patients, our COVID patients with CLABSI device had been in a really long time. So they were very, very late onset CLABSIs. So that has brought us to a strategy, because one of the things we gave up, like so many other places during COVID, was device rounds, getting the device out. It was more just like a default, like device is in, they're getting all these things. And there was not a lot of de-escalation or, you know, moving to less invasive lines, like whether PICs or midlines. It was more the central's in, we're keeping it in, and it would stay in for really, really long time. And then we were seeing the CLABSIs later onset. So it kind of all like makes sense, but also hindsight's 2020. So, but it is reinvigorated us to get back to device rounds regardless of the patient, right? There's no free pass because you have COVID, and that you're going to have a Foley, and you're going to have a vent, and you're going to have a central line. That's stopped. So that's a kind of an important takeaway.
Yeah, agreed. I think this will be an interesting look if they do, or if we do the exact same analysis and compare that 2020 to 2021 data. And then if we do it again for 2022, are we going to see, as we start going back to more of that infection prevention standard, does that data change again? Or does it go sort of back? Does it downward trend, or do we see more percent decrease? All really great points.
Ours is already coming down. You know, pretty dramatic.
That's awesome. That's wonderful to hear.
The COVID coming down. Yeah. So, but you know, we have to figure out, how do we hardwire our stuff regardless of what type of infection the patient comes in with, right? And that's where we have to really research and learn. we can't just succumb to these spikes every time a new pandemic hits. It's not sustainable. So. Well, thank you for sharing today.
This is Amanda. I have one more thing to add. Totally agree with that. And then one of the things that we saw that I thought was kind of unexpected was a decent amount of MRSA bacteremia attributed to just secondary pneumonia in COVID patients. So we saw that wasn't something, that I was expecting, but we saw a fair number of MRSA bacteremia events from that. And not necessarily from ventilated patients, just general care, pneumonia kind of patients. So.
Thanks. I find that really interesting because there's not a ton that really discusses sort of why we're seeing that MRSA bacteremia. So I find that very enlightening.
Same here, Amanda. We saw the same. And there, Amanda, one of the things we assessed out of that was a lot of our routine MRSA decolonization strategies had gotten put kind of in a parking lot during COVID, a lot of CHG bathing, screening and decolonizing for MRSA. So a lot of the standard things to reduce MRSA kind of got tabled. So we think maybe, and that's another thing we're bringing back into, practice, routine practice.
Yeah, agree. We talked about that mostly across the board with just the routine daily bathing, line care bundle, peri-care, like everything like that in a standard way, that got disrupted. And I agree with what you said. It can't just stop every time there's a pandemic or a flu surge or whatever, like just hardwiring that stuff is really critical.
Like non-negotiable, we have to be, I think, a little more, we're so used to being flexible in infection prevention. I think, what we've all learned is some things are non-negotiable, right? So like IV pumps in halls, that's not open for discussion. It's not an option. Things like that.
Well, I think, Lisa, to your earlier point, right, like we know that this is a patient population who's much more at risk. So if anything, these are the people we should absolutely be doing these interventions with, not avoiding them. Sharon, I don't know if you're connected to audio and want to unmute and share. I see you're putting a lot of great comments in the chat box. If you can just unmute and verbally share, that may be helpful.
Hey, Sharon, just to address your comment, I was really talking about like the clinical, like the patients clinically had a pneumonia that caused them to be bacteremic, not that they were like surveillance wise classified as a pneumonia. So just to clarify, it was really just a clinical picture. And most of them were not ventilated. I think those were more just the non-ventilated patients who appeared to have had a secondary pneumonia after COVID.
Thanks for weighing
I'm
in.
sorry, I think am I unmuted now?
Yes, Sharon, we can hear you.
Okay, I don't have a mic on my computer, so I had to unmute the computer and the phone, so a little technical difficulty here. So yes, some had pneumonia, but once they were put on the vent, then we couldn't call it secondary to pneumonia because it did not meet the VAP criteria. In fact, most of them were VACs, not even IVACs. And when we had patients with pneumonia, they came in with pneumonia, but the MRSA bacteremia was late onset, and they don't always get a sputum for pneumonia. So they had no evidence of MRSA in their sputum on admission, and by the time they had the MRSA bacteremia, it was far into their stay. So I suspect a lot of people had MRSA bacteremia because what they had is COVID at home, and then they had increased respiratory symptoms, and they were admitted after a week or two of being sick at home and finally couldn't deal with it and came in for shortness of breath or, altered mental status or whatever else it affected. So I think we have a lot of investigation to go on this COVID pandemic to find some real answers. And I agree with Lisa on doing some journal articles.
Absolutely. And
Get
Sharon,
on that, Sharon.
Yeah, I was just going to echo that, Sharon. Thanks for sharing your thoughts as well. And then a comment from Doreen, and this is something that our group has been talking about as well for regional hospitals that don't typically care for critical care patients. And because the large tertiary centers didn't have beds, those institutions were then caring for patients that they typically didn't. And then you're now seeing collapses or other events occurring in institutions that hadn't had any of those for years. So I certainly think, Doreen, that's a well taken point about just, you know, how do we educate? How do we continue deploying some of these practices, even for facilities that this may not be sort of bread and butter for them, but in emergency scenarios, it is important that they have the workflows and education and knowledge in place to be able to sustain some of this, you know, in that crisis mode.
This is Sharon again. Some of the HAI issues that we saw besides pneumonia, some of these need to be worked on. For one, when we have pneumonia, they often don't collect the sputum. So we should be getting sputums. It should be opportunities for improvement for patients with pneumonia. And by the time they understand what pathogen is causing the issue, they've been treated with lots of antibiotics, so it's not antimicrobial stewardship. Urines, we have a lot of patients that are colonized with bacteria, and some of them have MDROs that they're colonized, and physicians will get a urine culture without any symptoms, and then they start treating urinary colonization instead of symptomatic or asymptomatic bacteriuria instead of symptomatic bacteriuria. And so then that caused its own issue, and then leaving the catheters in instead of taking them out. With the COVID patients, because they were in ICU and sicker in I's and O's, has contributed to a lot of problems. So I think we could learn just general HAI prevention from some of the things that happened during the COVID pandemic, or that's still going on with the COVID pandemic.
And Sharon, I think to your point, you know, this really reveals an opportunity for us to see really what's going on, what practices are hardwired, what things went by the wayside when staff got stretched and things weren't functioning as we're used to, for us to be able to take a step back and say, okay, these are the areas or these are the things that we thought maybe were implemented and working well, versus those that maybe were in sort of standard operation, but when we got to crisis mode, just kind of fell off for one reason or another. So I certainly think there is, it sounds like great interest in doing something in that vein. Certainly, if nothing else, would encourage you as you have time and capacity to look at this and to see what this looks like for each of your facilities. Does it look like the data that Ellie shared? Does it match what Lisa shared? Is it different? Because I'm sure there are facilities who maybe saw decreases in a number of these. And again, why? So you're trying to understand really why that is and what makes your institution different from our state average or from Lisa's big analysis that she did across 69 hospitals, because there are going to be pockets where things are different. And so how do we learn from those successes, identify what those gaps and those challenges were? And then Sharon, to your point, how do we take that information, take those learnings moving forward, and do something with it to do good, you know, and change that process?
And I think another thing a lot of hospitals saw is in the initial COVID, they laid off a lot of nurses, surgical nurses, and then when they brought them back, the nurses were moved to all different floors. And we're really seeing that nursing is a specialty. You know, there's a med-surg nurse, there's a OB nurse, there's an OR nurse, and there really is a specialty. And you can pull them across to other floors and they can function as an RN, but all those protocols that we've been hardwiring have been specific for those floors. And we need to now teach the OR nurse more about how to prevent urinary catheters and collapses and all those kind of things. Their basic nursing functions are there, but they haven't been performing those duties for a long time.
Absolutely. Any additional thoughts or comments related to the discussion we've been having, or any reaction to the questions that are up on Ellie's slide as well? And I don't think we've heard much from our ambulatory surgery center, long-term care. So any of those folks who are on the call and have anything to add, I would love to hear from you. All right, if there's nothing additional on these points on Ellie's slide, I'll just open it up more broadly to see if there are any just sort of overarching comments, questions for Ellie on any of the information she presented, anything you want her to go back to and revisit, or anything that's kind of on your mind as we've been talking for the last almost 50 minutes.
Hey, this is Doreen. Can you hear me?
Hey, Doreen, yes, I can.
Okay, great. Yeah, just a question, and I don't know if I missed this, but we ended up having all of last year deferred our NHSN data from CMS. And this year hasn't been that much better of a year, and just curious if there's been any discussions around that.
Doreen, from a public policy committee at APIC perspective, we've seen nothing of that nature. We thought it was a big win when they included all of 2020, you know, versus just the first 6 months, but absolutely nothing about 2021 data from a CMS perspective.
Thanks.
And I don't think they're going to, Doreen, because I think they got a lot of flack for doing that in the first place. Because what it did is it took away our opportunity to study the impact of COVID on HAIs, right? Because, you know, you saw in that one article how many hospitals did not submit data to NHSN, the attrition. So I don't think they're gonna make that. I hesitate to call it a mistake because we all appreciated it, but they got a lot of heat. Sorry, Ellie, I didn't mean to jump in, but that's what I have gathered.
No, thank you. I don't typically have a perspective from what CMS is going to do or what they're going to change until all the rest of you know. So it sounds like you get a nice inside perspective. So I appreciate that. But we did, I mean, I can just speak to what we noticed, and I kind of brought that up a little bit in the data. From what we saw, we had about 10 or 15 hospitals, I believe, that did not report NHSN data during that time. And just to echo what Lisa had said, I mean, that would probably likely have an effect on the data and the numbers that we're seeing. So it does kind of change some of the information that we might be seeing, and does have possible effects on what the data would have looked like if those facilities were reporting during that time. Would it have changed our percentages? Would they have been quite as great, or would they have been less? So it would have been interesting to note, but definitely understand that there was a resource need there. So one way to try to identify those problems and create solutions.
Ellie, I don't know if you share this information and I missed it, but what was the percentages of Michigan hospitals that did not report for the 2 reporting periods?
Yeah, I used to have this data all up in the air, but so we have about 109, I believe, acute cares that report. And I think we had between 10 and 15. So you're looking at a little like a 10-ish% sort of facilities that didn't report during the quarters. I think it was, Lisa, maybe you can correct me if I'm wrong. I believe it started in 2019 Q4 and went through 2020 Q1 or 2, or maybe it was Q3 to 1, something like that. And there was 2 or 3 quarters in there that there was that exemption for reporting. So we saw about 10 or 15 acute cares. And this was pretty limited to an acute care a view of the data. So that didn't really relate to what we had for critical access hospitals.
You know, I would like to see NHSN make that COVID question mandatory within those publicly reported HAIs. And that way that could be risk adjusted. Then we have exclusion criteria for CMS built in, just like when you have a BMI over 50 on your SSIs, you know. So I do not understand why NHSN is a little behind the ball on making that field mandatory. So I don't know who has an in with the NHSN and the manuals that are being written for 2022. But somebody put it in their suggestion box.
Sarah, it's because they're asking for 18,000 data points on COVID HCP vaccine reporting. Maybe they should focus
too.
less on booster 1 or shot 1 or 2 and manufacturer and more on this.
Just put a little red asterisk next to COVID, yes or no, and I will be happy to give it to them. I've been giving it to them all along. I just think they need to make everybody give it to them. We were one of the hospitals, you know, that didn't stop reporting. We didn't exclude any data. We continued to see it. And we didn't see the same thing that you saw, Lisa. We saw, you know, an increase in HAIs, but they were COVID negative. As you know, they weren't heavily COVID positive. We had so many challenges and we continue to have challenges. So it doesn't make sense that 2020 gets a different out than 2021. So we got to be talking about how we're not hammering our hospitals and their reimbursement and their monies, because we're still dealing with the same problems we had last year. So we're dealing with surgical site infections, you know, and last year I thought it was because people were waiting too long. We had shut down coming in emergently. But we're still seeing issues with surgical site infections, and you know, we've done all the right things. So I don't see COVID as an impact there because we screen everybody before they're allowed to have surgery. So I don't know if anybody else is seeing the surgical site problems. I know the data that you shared, Ellie, showed an increase, but we're not really talking so much about that and what's driving that. That's my 2 cents. I'm done.
Yeah, thank you so much for bringing that up. Again, the same sort of questions that I have as well. And this data we can present over and over and over again. It's really, in my opinion, meaningless without your guys' perspective. So I so appreciate all of these different ideas and thoughts or things that you're noticing. So Sarah, especially talking about surgical site infections. Again, it's noted in this paper that there is an increase. It's a bit sporadic, so it's not quite as trendy, if you will, as the other HAIs. However, what is related to that? Was it those, I had the same thoughts. Is it because they were delaying surgeries? And so we were seeing maybe changes in the patient that they wouldn't have had if they'd had their surgery prior to. How do we answer those questions and where do we find that data? And I agree. I think some of it could be in the NHSN surveillance definition, and agreed it could be just going back and doing deeper case investigations as well in that medical record that we don't have access to in NHSN, at least from the group side, but something that you may have access to in your hospitals alone. So echoing the same thing that I think Kelsey and Lisa and everyone else has already said today is, if you have the capacity and the resources, here's an opportunity to really sort of dig in as to the why. Where are these data changing, or why are they changing, or are they different than what we're seeing state and national? And is it something to do with something specific in your hospital? If you're not seeing these things, what were you doing that others might not have been doing that impacted your HAIs in a positive way?
And Ellie, this is Chow. Just a comment, you know, since the state has access to this data, but I don't know if you would be able to calculate this data field, but what would be interesting is to understand whether there was also an increase in length of stay, you know, among the patients, just to kind of understand not just an increase in HAIs, but also in length of stay and the impact that it caused on the patient and their discharge.
Yeah. Absolutely for that. Thank you for that comment. It's one of the future directions I think I have for this data as to what do we look at next and what's important to look at next. So one of those things being in the, obviously all HAI data is length of stay, obviously length of device. So how long was the device in? Is that comparative? Are we averaging more days than they did in the previous, like the 2019 data? Also looking at one of the things they noted in this paper that I have not looked at in our Michigan data, but was also brought up in our last NHSN group meeting, was what type of isolates are we getting from our CLABSI being like Staph aureus and that kind of thing. So sort of important again, risk factors or other things that we should be looking at that could contribute to some of these numbers too.
Absolutely. Well, Ellie, thanks again so much for joining us. I know we're kind of coming to the top of the hour, so if I can just share a couple quick announcements with our group before folks sign off, and then we can go ahead and close out for today. So I just put a chat in the chat box, but just a reminder, if you have not already done so, please leave your name and your email address in the chat box so we have your attendance for today. This is really important because this is where we are going to send the survey link to get your CEs. And when we review that information, we will compare it against this list. So if we don't have your name, we don't have your email address, we will not be able to follow up with you or issue you CE credits. Here is the link. These slides will go out. The link will be in there, but if I don't even know, if you can click the link, it'll take you right there. But if not, again, we'll include it in the follow-up information that will go out and you can do it at that point. Just a quick reminder, I know this is sort of new, so I wanted to touch on this, but our session recordings for all of our education webinars have been posted on our very new YouTube channel. So if you have not already taken a couple minutes to look at that, please do so. We are only able to offer CE credits if you attend the sessions live. But again, just a nice opportunity to go back and refresh if there are things that are really impactful and meaningful. You'll be able to have all of that information at your fingertips, as well as all of the slides, which are posted on our APIC's Great Lake website. So links are there as well. This will go out in a follow-up email, so don't feel like you need to quickly click on all these or jot this information down. You will have that. And last but certainly not least, save the date for our December APIC Great Lakes Social. The date and time is there. Looking forward to getting together, spending an hour over lunch to just connect, recap the year, share, goods, bads, the ugly, and just kind of come together and support, celebrate the holidays. And we look forward to kind of ending this year on a strong note. As Amanda mentioned at the start of the call, thank you for all that you have done and continue to do for your patients, for your staff, and for everyone in your communities as well. I know so many of you are engaged, in schools and churches and other groups. So thank you for taking your infection prevention outside the walls of your institution. Happy International Infection Prevention Week. Thank you for being here, and we will see you guys all next time.
Thanks, everyone. Have a great afternoon.
Thank you.